Okay. Oh, yes, that's fine.
You like first names?
That's fine for me. Yes.
Yeah, I like that too because I know you as Tiffany.
Yes. And I know you were saying.
Yeah.
And so that's a question. When we transition from one another, do we transition the slides? Like, will Sam transition the slides to me and then I transition it back to her? Uh,
We both have control, right?
I mean, I'm sorry, not I think I was more. Yeah. Okay. Got it. Mhm. And
And
I
then
will
we'll be able to see what the other person does, right? Like, when I advance it, Tiffany will see that, right? Okay, okay. And one other question I have for you is when the other person is presenting, because like I have a section, she has a section, then I do, then she does. Um, will we still be on camera when we're not speaking? No. Excellent. Yeah. Okay. Good.
I have a question as well. This is my last question. So I actually see what I see is two, like I have to click from one screen to another. So right now what I see is a grid of all of us. But then when I have my next page up here, I click on my next tab and that's where I see the slides in the presentation format. So if I'm looking at the slide and the grid for all of us, right now I see Sam in the middle and she is, and then I can see her slides on that side with her in the middle. If I leave it here so that I'm not clicking back and forth, can I still see the slides advance? Okay. 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 It did. Yes.
Does this module have a number? Like, should I say welcome to module for pharmacotherapy for obesity? Is that something you want me to say, or just welcome to the module? Okay, like that. And then do I say what the program is, or just say, welcome to the module pharmacotherapy for obesity? Just that? Okay, okay. One. Welcome to the module Pharmacotherapy for Obesity. I want to introduce myself. I'm Sandra Christensen. I'm a nurse practitioner in Seattle, Washington, where I am the Chief Clinical Officer and Obesity Specialist at Integrative Medical Weight Management. And then I want to also introduce Dr. Tiffany Lowe Clayton.
Hi, everyone. My name is Dr. Tiffany Lowe Clayton. I am a bariatrician at Wake Med Health and Hospital System located in Raleigh, North Carolina. And I'm also an assistant professor and director of clinical education for Campbell University School of Osteopathic Medicine.
Thanks, Tiffany. Glad you're joining us today. So, our objectives for today are first that we want to summarize the mechanism of action, safety, efficacy, and dosing of medications for obesity treatment. And then we want to learn how to initiate, monitor, and switch medications for obesity in appropriate patients according to clinical practice guidelines. And the overall goal of this program is that you will understand the role of obesity medications in comprehensive obesity management, and you will feel comfortable prescribing and monitoring them in your patients. So, lifestyle interventions are the foundation of all good comprehensive obesity management, but they're rarely enough to really accomplish the health goals and quality of life improvements that our patients want. And so we also can consider adding pharmacotherapy and or metabolic and bariatric surgeries and procedures. And they can really help support the lifestyle interventions that we've implemented. So we're going to start with a case study, and I want to introduce you to Ellen. And I want you to think about Ellen as we go through all of the material today and think about the various medications and her particular health situation and how you might be able to help her. So she, in her obesity history, tells us that weight has been an issue for her since she was a teenager. But in the past 4 years, she's gained 40 pounds. She has tried all kinds of things to reduce her weight, and some are successful, some are not. She'll get her weight down and then she'll start to regain. And she's never seen a healthcare provider to talk about obesity management until she's come to see you. So, in terms of her social history, she works as a nurse. She's married with 2 teenagers, and her alcohol use is 1 time per week. She has a strong family history of obesity in her mother, father, and sister, who also have hypertension and diabetes, and she does not have a history of pancreatitis. In terms of her nutrition, she tries to be careful most days, but she really craves sweets at night, and that's a big challenge for her. And in terms of physical activity, she's not doing anything at this time. I just need to take a drink here. So in terms of her medical history and medications, she has obstructive sleep apnea. Yes. Yeah, I paused thinking you could cut that out. Is that not the right way to do it? Okay. Okay. So do you want me to go back to the previous slide before I come to this one? So go back here. Do you want me to present this slide again? Or just make the transition now? Now, I'd like to introduce you to Ellen. She comes to see you. She says that she's had a weight issue since she was a teenager, but in the past 4 years, she's gained almost 40 pounds. And she's tried all kinds of things over the years to reduce her weight. Some are successful, some are not. But what always happens is that she's not able to stick with her plan and she winds up regaining. And she's never seen a healthcare provider before, but now she's come to you asking for help. Social history, she works as a nurse, is married with 2 teenagers at home, and her alcohol use is 1 time per week. She comes from a strong family history of obesity in her father, mother, and sister, who also have hypertension and diabetes. She does not have a personal history of pancreatitis. In terms of nutrition, she tries to be careful most days, tries to limit what she eats, but she really craves sweets at night, and that makes it really difficult to limit them. She's not doing any physical activity at this time. In terms of her history and medications, she has obstructive sleep apnea and uses a BiPAP machine. She has GERD, hypertension, depression, and we stage her obesity as stage 2. Medications are metoprolol, 20 milligrams a day, omeprazole over the counter once a day, bordioxetine, 20 milligrams a day. She takes a multivitamin, and for pregnancy, she's using an IUD, and she has no known drug allergies. Now we'll have a polling question. What, if any, medication is Ellen taking that could be weight promoting? A, metoprolol, B, omeprazole, C, bordioxetine, D, more than one of these medications is weight promoting, and E, none are weight promoting. And the correct answer is metoprolol. So one of the most important things we can do when we're treating our patients for obesity is look at the medications they're on to see if any of them might be contributing to either weight gain or difficulty in reducing weight. And so we've got 5 categories listed here that are the most common categories where we see weight promoting meds. The first is diabetes, and insulin, sulfonylureas, pioglitazone, and let me start again on that one. I don't think I really know how to say that one. Okay. One of the most important things we can do when we're evaluating our patients is identify if they're on any medications that could be either contributing to weight gain or making it difficult for our patient to reduce their weight. And we call those weight promoting medications. We've got 5 categories that we're going to review. The first is the diabetes meds. So insulin is weight promoting, as are sulfonylureas. Pioglitazone and rosiglitazone are also weight promoting. Weight neutral are the DPP-4 meds, and then the weight negative are metformin, pramlintide, GLP-1 receptor agonists, and the SGLT2 inhibitors. In terms of hypertension, weight positive meds are beta blockers. More weight neutral are the ACE inhibitors, the ARBs, the alpha blockers, and the calcium channel blockers. In terms of miscellaneous meds, corticosteroids are also weight positive. In the antidepressant category, those that are weight positive are metaprazine, citalopram, paroxetine, and amitriptyline. And then weight neutral, and this can really vary person to person, is fluoxetine, escitalopram, sertraline, or vortioxetine. And I find that some patients might have weight gain with those meds, and some it might be weight neutral, and some even weight negative. But one of the most common weight negative medications for antidepressants is bupropion. The antipsychotics tend to be weight positive. Some are more neutral. Clozapine, olanzapine, quetiapine, risperidone, and lithium are all weight positive. And if possible, if we can shift people to more weight neutral medications that are listed here, and then there aren't any that are weight negative. So Ellen comes in for her first obesity visit. Her weight is 212 pounds. Her BMI is 36.3. Blood pressure is elevated at 142/88. Heart rate is 78. Her respiratory rate is 16, and her O2 sat is 98%. Her waist circumference is 42 inches. Her neck circumference is 15 inches. And screening tools, the PHQ-9, she has a score of 4. And her bed 7 is negative. Her PAR-Q and stop bang are negative, and the stop bang is likely negative because she's being treated on the BiPAP. So one of the easiest ways to get a quick picture of someone's history is to do the body weight graph, and Ellen has done this, and you can see that she has gained weight with both of her pregnancies, but then has been able to bring it back down. She did have some further weight reduction when she did a weight loss program in the community, and now over the past 4 years, she has steadily gained that 40 pounds. So in terms of Ellen's labs, her triglycerides are elevated at 174, her total cholesterol also at 236, her LDL is 134, and her HDL is suppressed at 48. She's got elevated liver enzymes with 67 AST and 102 ALT. Her vitamin D is in a good range. Fasting insulin is 18. Fasting glucose 94. Her HOMA IR score is 4.17, and her quickie score is 0.31. And so we can say in our evaluation that she's got elevated liver enzymes, hyperlipidemia. We know she has hypertension, GERD, obstructive sleep apnea, and depression. She's on that weight promoting medication, the metoprolol. And then in terms of staging her obesity, she's class 2 with the WHO designation. She's stage 2 for the Edmonton obesity staging system, and also stage 2 for the ACE staging system. So next, we're just going to review clinical practice guidelines and algorithms that are available to you for managing obesity, and in particular pharmacotherapy. So the Endocrine Society has a clinical practice guideline, as does ACE. And then the Obesity Medicine Association has the obesity algorithm, which is published every year and updated, and also clinical practice statements on pharmacotherapy and other aspects of obesity management. And then Obesity Canada also has clinical practice guidelines. And all of these organizations support the use of pharmacotherapy in comprehensive obesity management. It's also a consensus statement among the Obesity Society, the Obesity Action Coalition, Obesity Medicine Association, ASMBS, the Stop Obesity Alliance, and the Academy of Nutrition and Dietetics. And all these organizations have come together to say that obesity is a chronic, prevalent disease that's characterized by excess adiposity, and the way that it's distributed in the body poses a risk to health and requires lifelong chronic care. We know that all systems of the body are affected by obesity, and there's many complications of obesity, including type 2 diabetes, heart disease, and cancer. And that these groups all agree that everyone should have access to evidence-based comprehensive treatment. So as I mentioned, all kinds of organizations recognize obesity as a chronic disease that is serious in nature. And there's efforts underway to create one standard of care. And that would be one that would be focused on adults, would recommend individualized eating plans, counseling patients to increase their physical activity, providing behavioral counseling and interventions, and utilizing pharmacotherapy when appropriate, and then also referring to a obesity specialist or bariatric surgery center as needed. I'm now going to turn it over to Tiffany to talk about pharmacologic therapy for obesity.
Thank you, Sam. And so let's continue on to talk about using medication as part of obesity treatment. Why do we use it? Well, we know that medication and anti obesity medication is used as a part of a comprehensive program when we're trying to help our patients not just lose weight, but have sustainable weight loss. This is in an understanding that obesity is a chronic and complex medical problem, and it should be treated as such. So, utilizing medication as a viable part of the management of obesity will positively impact the patient and be able to help them achieve sustainable weight loss. We use it to help facilitate weight reduction, improve the adherence of nutrition plans, as medication can help with things such as appetite and craving. But perhaps most importantly, we also use it to counter the effects of metabolic adaptation, which is our body's natural response to preserve after a period of sustainable weight loss. This was actually evidence in a very small but pivotal study that looked at the hormone levels of individuals who lost a significant amount of weight over a period of a year. Their hormonal levels were looked at baseline, at week 10, and after 1 year. And what was found is that in those individuals, they had an increase of the hunger hormone ghrelin and a decrease of several of the satiety hormones, many of which you see listed here: GLP-1, GIP, CCK, polypeptide YY, insulin, and amylin, to name a few. There was also alterations in resting energy expenditure, as well as a loss of muscle mass, all of which can actually promote a weight promoting environment. And in some cases, patients can even gain more weight than they lost initially. Anti obesity medicine actually helps with that and helps patients to overcome that metabolic adaptation. And because of that, you've already heard that multiple medical societies actually recommend using medication in the treatment of obesity early on as a part of a comprehensive plan. Now, when looking at how these medications work and considering them, especially when looking at why people eat and how much they eat, we know that the brain is the major regulator of food intake. The brain, along the gut brain axis, impacts not just the amount that a person eats, but also looks at things such as why a person eats, things such as cravings and those type of things. When you look at different medications, there is no one size that fits all in medicine, and definitely no one size that fits all in obesity medicine. Each of the medications that are currently approved by the FDA used to treat obesity actually targets different areas of either the gut, the brain, or peripheral organs to not just help with appetite, but also can impact a person who may be having cravings as well. And so, a polling question: what percentage of weight reduction should be the first therapeutic goal? 5%? Or I'm sorry, less than 5%, 5 to 10%, 11 to 15%, or it depends on the individual's baseline body mass index. And the correct answer is B: 5 to 10% weight loss makes a significant difference. And so, when considering therapeutic goals, again, 5 to 10% weight loss makes a significant metabolic difference. And this happens pretty early on. As a matter of fact, when we look at the reduction of obesity related complications, it can occur as early as 6 months of that weight loss. We know that there are multiple medical conditions that have obesity as a major underlying factor. But helping patients with even a modest amount of weight loss can not only improve that patient's health by improving those medical conditions or even in some cases reversing them, but it also will improve the overall quality of the patient's life. With a modest reduction of 5 to 10% weight loss, we can see a reduction in cardiovascular risk factors. We can see the prevention or even the delay of prediabetes or type 2 diabetes, improvement in biomechanics such as osteoarthritis, improved sleep apnea, and then psychological improvements in patients in the reduction of depression, as well as improved physical function. So, when helping our patients understand the benefits of being able to lose weight, helping them to understand that this is a matter of physiology, not a matter of willpower, and something as simple as a 5 to 10% weight reduction will help them to stay motivated and stay compliant long term. And so, when we're considering which medication to use, there are different types of medications that are used for both short term and long term use. We're going to talk about each one of these in the next slides. But first, I'm going to take a look at the FDA approved short term obesity medications that are used. Here you can see that there are several, many of which you will see some of your patients be on. One of the most familiar is phentermine that we look at. All of these medications are anorectic medications or sympathomimetic medications that are used to decrease appetite. Because they do have a stimulant like effect and they do have a risk for dependence, they are historically considered controlled substances, and also are historically considered for short term use. Some of the contraindications that you need to be aware of when using these medications are patients who have a known history of cardiovascular disease, and a history of anxiety disorder because of the stimulant like effect. Also, in patients who are taking these medications, you want to be mindful of their blood pressures. And if they have a history of hypertension, especially uncontrolled hypertension, these would be patients that you would not want to use this as first line therapy. Patients who are on MAOI inhibitors, or patients with a history of glaucoma, hyperthyroidism, a seizure disorder, are also patients that these are generally contraindicated in, as well as patients who have been pregnant or who are actively getting pregnant. You want to not give these medications to those patients as well. And then, of course, patients who have a history of drug abuse, it's generally not a medication that we would choose as first line because of the risk of dependence. When discussing some of the side effects, you want to make sure that you're discussing these with your patients and watching out for things such as insomnia, heart palpitations, tachycardia, and dry mouth. There's also patients that have some complaints of alterations in their taste buds. And if it's something that's severe, you may want to consider whether you want to continue these patients on these medications or if you want to try something else as it relates to those as well. Now, when considering phentermine, which is one of the ones that you will actually see most commonly used, phentermine is classified as a Schedule 4 drug. Again, it is a controlled substance used for um, that's typically FDA approved for a maximum of 13 weeks, although it is frequently prescribed off label for long term use. This is after it's seen by many experts and the Obesity Medicine Association that states that longer use than 12 weeks is supported by data and opinion leaders and has been shown to be very effective in helping those patients be able to lose weight and sustain their weight loss long term. It does cause a weight loss of 7.38% compared to 2.28% in the placebo. This was seen in a 28-week trial. Now, with that being said, every state is different in terms of the length of time that you are able to give this medication to patients. So make sure that you are familiar with your state laws and also ensure that you are monitoring your patients closely. The Endocrine Society allows for possible long term use as long as patients have no previous history of cardiovascular disease or any psychiatric or substance abuse history. Again, those would be contraindications. They also recommend that we inform our patients about other therapies that may be used for long term use, and then document that you are using this as a off-label long-term treatment in patients and that that you are monitoring them closely. You also want to make sure that you're monitoring their pulse and also their blood pressure on a regular basis to ensure that it is not elevated. And then you want to demonstrate significant weight loss with phentermine. Again, we're looking at that 5% weight loss goal at minimum for patients to say that this medication is effective and that it's going to be justified in using it over a period of time. In the patients, you always want to start at the lowest effective dose. Usually, in this case, it's 7.5 milligrams, and then increase to where the medication is going to be the most effective for the patient and that the patient can tolerate it. Dose escalate if they have not achieved weight loss, but if they've been on the medication for greater than 12 weeks, recommendations are that you should then consider alternative medications. There are certain studies that we can look at to look at the effectiveness of this. One of these is a portal electronic health records analysis that looked at a little over 13,000 patients, looking at phentermine at the 37.5 milligram dose for at least 12 months of continuous enrollment. The conclusion was that the longer duration of phentermine, so anything greater than that 3 month period of time, is actually associated with greater weight loss up to 2 years after initiating the treatment. Patients prescribed phentermine for less than 3 months, which is the current label direction, did not experience durable or clinically significant weight loss. And so phentermine is effective for safe effective and safe for longer term use in low risk individuals. But again, you want to make sure that you are assessing your patient's risk as well as documenting that they are low risk for the use of this medication. There is a trial that is now currently being recruited called the LEAP trial, which stands for long-term effectiveness of phentermine. It is a randomized double-blind trial that's going to be looking at the long-term effectiveness of phentermine in comparison to placebo. The trial will have approximately 1,000 participants across 5 clinical sites in the United States, and it's going to have a targeted enlistment of approximately 30% of underrepresented groups and 25% of male participants. All of these patients will meet the criteria of having a body mass index of greater than 27 in the setting of at least one weight related comorbidity or a body mass index of 30, and will all be patients over the age of 18 years old to the age of 70 years old. They are going to allow for patients who have diabetes and hypertension to be included as a part of the study. However, patients who have a history of heart disease or a history of however, patients who have a history of heart disease or stroke will be excluded from this study. What it will measure is the safety and efficacy of the long-term effects of using phentermine as it relates to cardiometabolic parameters. This will include blood pressure, the changes in a patient's lipids, the changes in their blood sugar, as well as their waist circumference. It will also assess the amount of weight a patient may lose based on, let me restart that again. What it's actually going to measure is the weight reduction from baseline, as well as long term safety and efficacy as it relates to cardiometabolic parameters, including blood pressure, changes in the lipid panel, blood glucose, as well as waist circumference. All right. Okay. I just got to get my train of thought. I'm sorry. Okay. All right. There are also medications that are FDA approved for long term use in obesity treatment as well. GLP-1 receptor agonist and tirzepatide, which is a GLP-1 and GIP dual receptor agonist, are both approved as injectable forms of medication, and you'll hear more about this in a few slides, as well as naltrexone, bupropion extended release, which is an oral medication, as well as orlistat, phentermine topiramate extended release, are all used for long-term use. Naltrexone and bupropion is an opioid receptor antagonist. I'm sorry. Let me go back to this slide. I just want to make sure I'm reading this correctly. When doing this particular slide, and this is taking a break, do you want me to go through and read each one of these mechanisms of action, or is this okay that they can actually see this? Okay, okay, got it. Um, they're still on the right. Oh, okay. Does it look okay, or should I be looking at the? Okay. Okay. All right. So now let's move on to the medications that are FDA approved for long-term use. Here you can see that we have several medications that are approved. Our oral medications are naltrexone, bupropion extended release, orlistat, and phentermine topiramate. All of these are approved in patients ages 12 and over for, I'm sorry, I'm saying that wrong because naltrexone is not. Let me do it one more time. I'm sorry. I'm going to get off this slide, I promise. Now let's move on to medications that's approved for long-term use uh, by the FDA. Here you can see oral medications, including naltrexone and bupropion extended release, orlistat, and phentermine are all oral medications that are used for long-term treatment. In addition, you have the injectable medications that we'll also discuss, including liraglutide, semaglutide, and tirzepatide, which is a both a GIP and GLP-1 dual receptor agonist. Looking at the weight reduction of each one of these, you can see that they're all effective at helping patients to lose that 5% goal that we talked about earlier. Orlistat, which is one of the oldest medications that uses, has only a modest weight loss of approximately 3% after a 2 year period of time. But the others are all effective at helping your patients be able to lose weight and have sustainable loss long term. Some general considerations when considering pharmacologic initiation. Again, there is no one size that fits all in medicine. And so you want to make sure that you consider your patient. Definitely talk to your patients, figure out what they are willing to do and how many pills a day they may want to take, or if they're comfortable with injecting their medication. Every patient responds to medication differently. If you have a patient who is on a specific medication and they do not have that response of at least a weight reduction of 5% after a 12-week period of time, the guidance is to switch them to another medication. This will also be the case if your patient starts to experience any side effects or if there are any contraindications that may come up. Additionally, All of these medications have not been studied in patients who are pregnant. So, if pregnancy does occur, the recommendations is to stop the medication as soon as you become aware that they're pregnant. And then also really measure the risk to benefit ratio in any patients who may be breastfeeding or during that lactation period. In that particular case, you may want to consider whether you want to have a disclosure signature that someone is not actively trying to get pregnant, or that they're aware that if they were to get pregnant, they would need to stop those medications and have the documentation of that to ensure their safety. Okay, so now let's look at each one of these medications one by one. Naltrexone bupropion extended release is used as a combination medication with a dose escalation over a 4-week period to 2 tabs twice daily. One of the things to be mindful of is that this medication does lower the seizure threshold. So you want to be careful with any patients who have a history of seizure disorder. You also want to wait approximately 2 weeks after stopping an MAOI inhibitor to lower the risk of side effects like hypertensive crisis, confusion, agitation, or serotonin syndrome. Regarding the naltrexone component of this medication, be careful with any patient who is on a chronic opioid or who has active alcohol withdrawal. You also want to make sure you're careful with any of these patients who have any renal or hepatic impairment. Some of the known side effects of this medication includes nausea and constipation, headache, dizziness, vomiting, insomnia, or dry mouth. So you want to make sure that you are giving your patients anticipatory guidance as it relates to this. Additionally, monitor your patients closely. Because bupropion is a norepinephrine uptake inhibitor, it can also create a transient increase in their blood pressure. And so, if that occurs, you want to use your clinical judgment to see if this medication can continue. Other practical considerations is you want to make sure you let the patients know that they need to titrate their dose on initiation, and then also monitor for any worsening of depression and or anxiety in these patients. There are two studies that we want to look at as it relates to the effectiveness of this medication. The Core 1 and 2 trials, which is the Contrave obesity research trials, these were two of the four 56 weeks clinical trials that evaluated effectiveness of naltrexone bupropion extended release in the treatment of obesity. These trials enroll patients with a body mass index of either 30 or 27 in a setting of one weight related comorbidity and treated patients along with lifestyle modification. 50% of the patients taking the medication completed the trial versus 49% of those who were on placebo. 62% of patients achieved greater than 5% of weight loss versus 23% taking placebo, which is about an average loss of 18 pounds. So this medication is actually very effective in helping patients be able to lose weight. There was also the Light trial, which was an original investigation in 2016. This trial was actually to determine whether the medication increased the risk for major adverse cardiovascular events, which would be CV death, non fatal MI, and non fatal stroke. In this trial, however, there was a public release of confidential interim data by the sponsor, and so academic leadership chose to end this trial early. While the upper limit of the confidence interval did not exceed 2.0 of the early termination, it's not possible to assess whether there was non inferiority for the pre specified upper limit of 1.4. Therefore, cardiovascular safety still remains unclear as it relates to this medication in particular, and more research needs to be done. Orlistat is the next medication that's approved for patients ages 12 years and older. With orlistat, it starts at a dose of 160 milligrams, and the Maintenance dose is 120 milligrams given 3 times a day within 1 hour of taking a fat containing meal. There was, again, a modest weight reduction of anywhere between 3.9 to 10.2% at 1 year in 17 randomized clinical controlled trials. And there was also some improvement in the cardiometabolic parameters, including blood pressure, triglycerides, and the lipid panel, as well as an improvement in fasting glucose at a year. It also slowed the progression of type 2 diabetes in these patients. With that said, that does cause chronic malabsorption, and so many patients find that it's very difficult to tolerate. If a patient is going to be on this medication, you want to make sure that you are also educating them about taking in a well balanced but low fat diet to be able to reduce some of the side effects that they can have, including oily spotting and cramps, as well as flatulence, which all can be limiting to a patient being treated with orlistat. Additionally, we also want to consider our patients to take a fat soluble vitamin and also make sure that you counsel them on the risk of the GI side effects and to uh, contact you if they start having any problems as it relates to this. There was the Zendos trial, which was a 4 year double blind placebo controlled trial, which was an prospective study. I'm so sorry. I didn't, I'm sorry, my phone just rang. Okay, I have to turn down the volume. Let me start again. Looking at the trial for orlistat, the Zendos trial, which was a 4 year double blind prospective study that looked at patients who took orlistat 120 milligrams 3 times a day versus placebo. The primary endpoints of this trial was time of randomization to the onset of type 2 diabetes and change in body weight. 52% of the patients who took orlistat versus 34% of those who were on placebo actually completed the trial. And the incidence of diabetes with placebo was 9% versus the incidence being 6.2% with orlistat with the risk reduction of 37%. In terms of weight loss, the reduction in weight was 5.8% with orlistat versus 3% with placebo. So the conclusion was that compared with lifestyle changes alone, orlistat plus lifestyle modifications resulted in a greater reduction in the incidence of type 2 diabetes over that 4 year period of time and produced greater weight reduction in a clinically representative population with obesity. Phentermine topiramate extended release is also another medication that we can consider for our patients. Here you want to initiate treatment at 3.75 over 23 milligrams for 2 weeks, and then do a dose escalation as well as long as the patient can tolerate it to increase to 7.5 over 46 milligrams, and then further dose escalate to a maintenance dose of either 11.25 milligrams or 15 milligrams over 92. I'm going to start again because that's very clunky. Phentermine topiramate extended release is another medication that we can use. And here you can see that a dose escalation occurs from 3.75 over 23 milligrams to a maximum maintenance dose of either 11.25 over 69 milligrams or 15 milligrams over 92 milligrams, depending on what the patient can tolerate. In this medication, there is a weight reduction of approximately 10% for those who were treated versus only 2% in patients who were taking placebo. And again, there was an improvement in the cardiometabolic markers as well as a reduction in the progression of type 2 diabetes. In these patients in particular, again, I want to mention that it does contain phentermine, and so there is a risk of dependence with these patients. And so you want to make sure that you see them regularly to ensure that they are doing okay on this medication and that you're not having any side effects. You also want to ensure that you're watching for hypertension, glaucoma, or the use of MAOI inhibitors as well. Some of the side effects are very similar to what we already discussed as it relates to phentermine with these medications. This is a controlled substance. So you do have to see these patients in your office on a regular basis. And you also want to make sure that you counsel them for any mood disorders or any suicidal ideation. Once you get to the highest dose, taper the highest dose every other day for 1 week if discontinuation is necessary in these patients. This particular medication, you don't want to just abruptly stop the medication to limit the risk of side effects. So the study that looked at the effectiveness of this was the phentermine topiramate extended release as an adjunct to surgical therapy in patients with a body mass index of greater than 40. In these patients, they were all undergoing laparoscopic sleeve, and these patients were to receive phentermine topiramate 3 months preoperatively and then continue the medication 2 years postoperatively. What they found was that there was a significant increase in the odds of achieving a body mass index of less than 40 for the experimental group compared with the control group at 6 months. So, again, in addition to lifestyle modification, taking phentermine topiramate extended release was showed superiority in just lifestyle modification and the surgery alone. And now I'm going to turn it back over to Sam, who will discuss liraglutide and the other GLP-1 receptor agonists.
Thank you, Tiffany. So we're first going to talk about liraglutide. This is the first GLP-1 receptor agonist that was approved for obesity, and that was 10 years ago in 2014. This is an injectable medication that people administer daily. We start with the zero point 0.6 milligrams, and people take that dose for a week and then increase by zero point 0.6 milligram increments until they reach the target dose of 3 milligrams. The scale trial with this showed that they lost about 9% of their weight at 1 year. And we also have another trial that shows that it reduced progression of prediabetes to type 2 diabetes. And there was less risk of people having a weight recurrence at a year. Like all GLP-1 agonists, we want to follow the black box warning. It's contraindicated in anyone with a personal or family history of multiple endocrine neoplasia syndrome type 2 or medullary thyroid cancer. And then anyone with a history of pancreatitis, we want to be very cautious with. And of course, as all the other medications, contraindicated during pregnancy and breastfeeding. And common side effects are primarily nausea, some vomiting, constipation is more common than diarrhea. For those with type 2 diabetes, we can see hypoglycemia, increased heart rate, and risk of pancreatitis, as well as increased lipase. And so when I discuss the other GLP-1 medications in this category, they will all have the same contraindications and primarily side effects. I'll point out those that are different. So anybody that has a history of gastroparesis, we want to use these medications with caution. This is a medication that has been approved for use in age 12 and up. So it's an option for teenagers. All of that being said, the company is not currently manufacturing liraglutide for obesity. So we're kind of in a lull period. It's expected that in 2026, there will be generic options available. So this is one that I'm not able to find at pharmacies anymore. And so keep this in mind, but put it on hold for now. So the SCALE obesity and prediabetes trial was an almost 3-year trial. Folks did there were two groups, the medication group getting the liraglutide 3 and then the placebo group. It involved over 2,200 adults that had a BMI of at least 30 or 27 with a weight-related complication and prediabetes. And they titrated up and then did the medication for nearly 3 years and then did a 12-week period where they were off the medication. and really nice results. 80% of the participants were less likely to develop diabetes versus the placebo group, and 60% reverted to normal glycemia. And for those that did develop type 2 diabetes, it took 2 to 7 times longer. Now we'll talk about semaglutide. This is semaglutide 2.4 milligrams. This is also an injectable medication, but it's only dosed once a week. We start with the 0.25 milligrams, then and we do that for 4 weeks. And if folks are tolerating that, we would go up to the 0.5. Next increment would be 1 milligram, then 1.7, and then the highest dose is the 2.4. And the trial, step one trial showed a mean weight reduction of 14.9%, so nearly 15% at the 68-week mark. We saw improvement in cardiometabolic risk factors, waist circumference, systolic and diastolic blood pressure, and then, of course, a reduction in BMI. For this medication, same side effects as liraglutide. I think constipation more common than the vomiting. Folks may get more reflux symptoms with this. Strategies for this medication and others in the category to reduce those side effects or to make sure that people eat small, frequent meals, that they stop eating when they're full, and that they avoid kind of high fat or the combo of high fat, high sugar meals. We want to make sure our patients are drinking enough water because when their appetite is suppressed, they often aren't consuming enough fluids. And so it's really important to encourage them to eat and drink frequently. It's common for people to have more nausea if they haven't eaten. And so it happens more frequently in the morning. So typically, if you're feeling nauseous, you don't want to eat. And then if you don't eat, the nausea gets worse. So I encourage people to have kind of bland foods, scrambled eggs, soups, cottage cheese, yogurt, protein smoothies to kind of get them through that period of nausea. We can also prescribe antiemetic medications, particularly as people are titrating their doses up and are more likely to have side effects. And that can help people get through. This medication comes in individual one-use pens. So the full dose is in the pen, comes in a box with 4 pens. And then we already talked about the side effects. Also, if someone isn't tolerating a dose or isn't fully tolerating, you can have them take the same dose again for another 4 weeks until they adjust. Maintenance doses for this medication are 1.7 and 2.4. So this is the step one trial that I was referring to. This had over 1,900 patients. And the FDA labeling criteria of a BMI of 30 or 27 with a rate-related complication. And what I really want to point out about this is something Tiffany was mentioning, that most of the weight reduction occurs typically in the first 6 to 9 months. And you can see that on the curve, the purple line on the top graph, that at about 44 to 52 weeks, we start to see weight reduction level off. But what's really notable about this trial is that over 86% had at least a 5% weight reduction, and 69% had a 10% weight reduction. So this is when we're getting into numbers that can have a really positive benefit on health. You can also see that 50% of the participants lost at least 15%, and 32% lost over 20%. And so that's really clinically meaningful and can make a significant impact on both cardiometabolic risk factors as well as quality of life and health risk. So we have entered a new era of anti-obesity medications where trials are being done and completed that are looking beyond just weight reduction. They're looking at health improvements, reduction in cardiovascular risk, and cardiovascular events. And the first trial to be completed in this category is the SELECT trial, and this data was released in 2023. This was a large trial with over 17,000 participants. They needed to be at least 45 years old and have a BMI of 27 or greater with a pre-existing cardiovascular disease that was defined as history of a MI, a stroke, or a peripheral artery disease. And what was found is that there was a 20% reduction in major cardiovascular or cardiac events, excuse me, which are defined as fatal or non-fatal MI or a fatal or non-fatal stroke. And that was compared to placebo. And this is really great news for our patients with a history of these conditions. And as a result, for the first time ever, we saw an obesity medication get a second indication for people that have obesity or overweight and cardiovascular disease history, that this medication can be prescribed. In response to this, Medicare covers this medication for folks that qualify that have had an MI or a stroke or have peripheral artery disease. There are some Medicaid programs that are now covering this medication for this indication, even if they don't cover it for general obesity. My state in Washington is one of those. I know Montana is another one. I'm sure there are more that I don't know about, and probably more coming. So this is the really great news for this medication and all meds in these new categories. So another study of interest is the STEP-HFpEF trial, and this was looking at folks that have obesity, or actually in this case obesity, had to have BMI of 30 or greater, and HFpEF. And so there were over 500 patients in this trial, and the things they wanted to measure are what's their reduction in body weight and what's their improvement in their everyday functioning. So they used the Kansas City cardiomyopathy questionnaire that looked at their physical functioning and their ability to tolerate exercise. And you can see on the graph, the upper graph, that those that were on the semaglutide had a change in their score of 16.6 versus 8.7 for the placebo. And then we saw a nice body weight reduction of 13.3%. The reason this is so significant is that these people have obesity and they have heart failure and a really compromised ability to be physically active. And so to see a 13.3% body weight reduction is really significant, as well as the improvement in their functioning. There was also a STEP-HFpEF trial that included patients that had type 2 diabetes, so obesity, heart failure, and diabetes. And we saw nice reduction in their weight of 9.8% compared to 3.4 placebo, and then an increase of 13.7 in their KCCQ score, their physical functioning. And so when this is even more challenging, people with diabetes don't lose weight as easily as people without, and they have heart failure and obesity, and we're seeing an almost 10% weight reduction. And so hopefully we'll see some FDA indications for this medication for this issue. Now we'll talk about tirzepatide. This is the latest obesity medication that we have. This is a GIP and GLP-1 receptor agonist. This medication starts off with a dose of 2.5 milligrams. There are 6 strengths. Each one goes up by 2.5 milligrams. So 2.5, 5, 7.5, 10, 12.5, and 15. Maintenance doses are considered to be the 5, 10, and 15 milligrams. Just like semaglutide, you start folks off with taking this. They take the same dose for a month. If they're tolerating it, then you increase the frequency, or excuse me, you increase the dose for another 4 weeks. And same advice in terms of managing the side effects. I do find with this med that there's less constipation and than there is with semaglutide, and more incidence of diarrhea. I find this medication is tolerated for most people better than the other GLP-1s that we have in the category, and really nice weight reduction of 15% for the 5 milligram dose, 19.5 for the 10 milligram dose, and 20.9, so almost 21% for the 15 milligram dose. Um, it's important with this medication because it does delay gastric emptying that you really monitor your patients closely for any conditions in which they're taking oral meds to things like depression, blood pressure, cholesterol meds, to make sure that they're not impairing the absorption. And what's very important with tirzepatide is that for women that are on an oral hormonal contraceptive, that when they initiate therapy for the first 4 weeks, and then for the first 4 weeks of any dose escalation, that they use an additional barrier method or switch to a non-oral contraceptive. And so if you think about the whole period of titration as 20 weeks, if everything goes well, it might be worth it to switch them to something else that's non-oral. Okay. So I was referring to the weight reduction with this that was seen in the SURMOUNT-1 trial. This was a large trial, over 2,500 folks. And as you can see here in the top, that we see really nice weight reduction. And then in the bottom graph, it shows how many people lost at least 5% of their weight. And even with the 5 milligram dose, 85.1% lost that much, and up to 90.9% with the 15 milligrams. And then also 78.1% of the patients taking 10 milligrams lost at least 10% of their body weight, and 83.5% lost at least 10% with the 15 milligrams. And then 50% of those that were taking the 10 milligrams lost greater than 20%, and 56.7% taking the 15 milligrams. So this is really significant weight reduction with this medication. So another trial done on tirzepatide is the SURMOUNT-OSA trial, and this was done on folks that had both obesity and obstructive sleep apnea. The two doses that were tested in this group were the 10 and the 15 milligrams. There were 469 patients in this group, and they were divided into two groups, those that were not treated with positive airway pressure and those that were. And for those that were not, there was a 55% reduction in their apnea-hypopnea index compared to 5% for placebo. And we saw 18.1% weight reduction in that group. And then those that were on the PAP therapy had even greater AHI reduction of 62% and greater weight reduction of 20.1%. This is also significant because we know that untreated sleep apnea and sleep apnea in general can make it harder for people to both reduce their weight and maintain it. And so showing that this medication is helpful both in reducing weight and improving sleep apnea is significant. I also want to mention that there are other trials that we're just starting to have data come in on for both semaglutide and tirzepatide that are showing slowing of progression from prediabetes to type 2 diabetes. There's trials looking at obesity and chronic kidney disease, liver disease, osteoarthritis, and other cardiovascular outcomes. So really be looking, because there's going to be a lot more data coming in to show that these meds not only improve obesity, but improve other health conditions that are related and improve quality of life. So just to review all of the studies that both Tiffany and I have discussed with you, we've got the orlistat trials, and you can see the blue bar is those that were getting the medication, and the reddish bar are those that are on placebo. And we've got the red dotted line shows 5% weight reduction. So with orlistat, we saw up to 10% body weight reduction in both the trial of the med in general for weight reduction, and then in the Zendos trial, which was looking at the progression of type 2 diabetes, or excuse me, prediabetes to type 2 diabetes. And then for the phentermine to pyramate in the EQUIP trial, which was looking at weight, and then the CONQUER trial, which was looking at weight and other comorbidities. And then for the naltrexone bupropion SR, the CORE 1 trial looked at those just to see weight reduction. The second one looked at weight reduction with people that had dyslipidemia and or hypertension. And then the CORE behavior modification trial provided group counseling to folks as well as the medication. And you can see that in that trial, that lifestyle counseling increased the weight reduction in the placebo group of 5% weight reduction, and then but higher in those that got the med. And then in terms of our GLP-1 medications, the scale trial showed 8% weight reduction, and then the scale maintenance. So this looked at folks being on the med for 2 years, and we see greater reduction, weight reduction that occurred in that second year. And then for the semaglutide, the step 1 was the weight reduction trial. Step 3 included intensive behavioral therapy as well, and you see a little bit higher weight reduction at 16%. And then the step 4 was the maintenance trial. So that was 2 years being on the med. We saw 17% weight reduction. And the step 5 trial looked at people being on the med for 2 years. And then the step teens was in adolescents. And then finally, the tirzepatide trials, SURMOUNT-1 was a weight reduction trial. SURMOUNT-3 was looking at a 12-week period where they got intensive lifestyle therapy before they started on the med. And you saw greater weight reduction there of 25%. And then the SURMOUNT-4, which is the maintenance trial, and 25% reduction there. And then just reminder of the tirzepatide that we see the 15 milligrams dose having 20.9% weight reduction. So now I'm going to talk about rare genetic causes of obesity and the treatment that's available for those. So there's up to or greater than 20 genetic disorders that are very rare, and they contribute to really early onset of severe obesity, typically seen at less than a year of age. And a lot of folks have this insatiable hunger. And so genetic testing is available that's free. In order to qualify for this, the patient has to be less than 18 years of age with their BMI in the 97th percentile, or greater than 19 years of age with a BMI of 40 and a history of childhood obesity before age 10. I have done this genetic testing on some of my patients. So far, everyone's come back negative, but it's something to consider in if you treat children or if you treat adults with this profile. So medication that's available for that is the setmelanotide. It was approved in 2020 and is used for these different genetic disorders. And so it can be used in children and adults age or older than 6 years old. It's an MC4 receptor agonist, and something to consider for those folks as well. So one trial that was done for treating the LEPR deficiency, there were 11 participants, and it was just found that 45% of them had at least a 10% weight reduction. And now I'm going to turn this back over to Tiffany. And now I'm going to turn this back over to Tiffany, who's going to talk about how to prescribe these medications for our patients.
Thank you, Sam. Okay, so now let's talk about steps to prescribing an obesity medication. First, we want to determine if our patient meets indications for obesity medications. Again, that body mass index of greater than 27 with one weight related comorbidity or body mass index of greater than 30. Then we also want to consider complications, comorbidities, or other conditions or symptoms that would benefit from a particular medication. We then want to screen for contraindications and medication interactions, discuss options with our patients, including insurance coverage and cost. We want to choose, initiate, or titrate the medication as necessary, and then monitor for response and titrate or switch the medication as appropriate. So now let's move back to our patient, Ellen. For step one, if we look at determining whether she meets the indications, she does. She has class 2 obesity with a body mass index of greater than 36.3. We also then want to go into her complications or comorbidities and other problems that she may have. Ellen has a history of insulin resistance. She had a problem with cravings. She had a history of depression, and she also had hypertension, but it was controlled. So that's something to keep in mind. When thinking about which medication is going to be the best medication to give, look at what her other comorbidities are, as well as any other problems that the patient may have that would benefit from any one particular anti obesity medicine in particular. When considering topiramate or phentermine topiramate, you can ask yourself, does the patient have attention deficit disorder, which actually can be improved by taking this medication? Do they have any problems with focus? Or do they have migraine headaches, which can then be made better if they're using topiramate? Also, their fatigue or energy levels may also be improved. When thinking about naltrexone and bupropion, do they have a history of coinciding depression, which actually may be improved? Have they had issues with alcohol cravings, or are they smokers? Because all of these things can be helped with this medication. And if they're taking any GLP-1 or GLP-GIP agonists, do they have a history of diabetes or prediabetes, or even metabolic syndrome, or MASLD or MASH, which was otherwise known as non-alcoholic fatty liver disease previously? Again, all of these things can be approved. And Sam talked about the benefit for cardiovascular disease in patients with these injectable medications. So just consider what's happening, because you may be able to kill two birds with one stone and really help the patient overall with the medication that you're using to also help treat obesity. Then we want to also look for contraindications with the medications or reactions. So with Ellen, we already know that she had a side effect with orlistat, but she had no other allergies or any other contraindications, and she had no previous history of pancreatitis, which is important when we're considering something like a GLP-1 receptor agonist. So then discuss the options with your patients, including insurance coverage and costs, because that's extremely important. In this particular case, Ellen actually did not have any insurance coverage. And so, when considering this patient with insurance coverage, one of the things that's going to be important to consider if they have coverage is whether they need a prior authorization. Many will require step therapy, but also will require that there's a documentation of lifestyle therapies that are put in place for our patients. Some of the plans, although they have insurance, may also have higher copays, and that may become limiting for the patient as it relates to cost. But there are manufacturers that have savings cards. And so, if that's the case, then you want to make sure that you're aware of what those savings cards are so that you can pass that along to your patients. More and more, we're starting to see Medicaid programs that are providing coverage. My state, North Carolina, just got Medicaid expansion, and we are now providing coverage for the GLP-1 receptor agonist, which is great, but all states are not there yet. And in California, it does not require pre authorization. And so that's something to consider as well. Without coverage, when we're considering injectable medications like tirzepatide or semaglutide, they're really expensive for patients to pay cash for, and that could be limiting to the patient. There are manufacturer coupons that are available for that, but the cost can still be $550 for tirzepatide, and for semaglutide, it can still be $650. And so you do want to make sure that you have this discussion with your patient of whether they can afford this. For tirzepatide in particular, there are vials that are now available. That is now a new development in the 2.5 and 5 milligram dose of this, and they are a little less expensive for the patient. So it may be something that the patient may be able to manage. But again, have that discussion with your patient. Phentermine topiramate and naltrexone bupropion are also all available for $99 a month. That is through a manufacturer subsidized mail order. You'll have to mail it directly to them. But if that's chosen, then that could be a viable option for your patients. And so, when you're going through coverage for the medications, the majority of the prior authorizations are done by Cover My Meds. But then with self-pay programs, there you can look on the website that they have with some of the pharmaceutical companies. Some of them do have self-pay programs that will help the patient be able to afford the medication. Then these are some of the links that you can see here that are below. So now a polling question. Think about Ellen. What medication would you recommend for her? Naltrexone bupropion extended release, orlistat, phentermine topiramate extended release, or semaglutide? And we'll move on. Looking at Ellen and with shared decision making, you are considering these medications. When we think about the relative contraindications of those medications, let's take a look at each one of these specifically. We know she already could not tolerate orlistat, so that wouldn't be an option. And then because she does not have insurance, the injectable medications, including liraglutide, semaglutide, and tirzepatide, would not be options as well. And Sam had already discussed that supply for liraglutide in particular may be difficult to find. So our available options would be naltrexone bupropion extended release, phentermine, or phentermine topiramate extended release for her. But again, she does have a history of hypertension, so that's something that you want to take into consideration. In this particular case, we chose to go with naltrexone bupropion as the first line treatment for her. And again, it is a dose escalation over a period of 4 weeks to a maximum dose of 4 tablets per day. We're also looking at an effective treatment response of at least 5% weight reduction from baseline at 12 weeks after maximum dosage, as well as those improvement in the cardiovascular risk factors. So improvement of her blood pressure as well as improvement of insulin resistance for her. And so at Ellen's follow-up visit in 2 to 3 weeks, you want to make sure that you monitor response and titrate or switch the medications as appropriate. So when Ellen arrived back in those 2 to 3 weeks, she's doing much better. She's tracking. You're going to evaluate the blood pressure medication. You can evaluate if she's still taking the omeprazole. Did her reflux symptoms improve, and did she have any side effect of the medication? And then also, did she start intensive behavioral therapy as it relates to her physical activities? Also, you want to make sure that you're always discussing treatment goals with your patients. You want your goals to be specific, measurable, achievable, relevant, and timely goals, otherwise known as SMART goals, that you want to set with your patients. And these are really goals that you want your patients to set for themselves. Patients will be much more apt to do what they set as opposed to what you tell them to do, but make sure that it's reasonable for your patients. And so Ellen's goals are to increase the medication to get on the full dose of the medication. And now she's eating 95% plant-based diet or whole food diet. She's ready to increase her physical activity. She wants to go to jujitsu and then also continue to have her steps, at least 7,000 average steps per day. And then she also wants to have some stress management or self care when she's enjoying listening to a book. So now she comes back in 3 to 4 weeks and you check to see how she's doing. Her weight is now down to 198 pounds. Her blood pressure is controlled. She has no side effects of the medicine. She's continuing to do a really good job at tracking her food, which we know is extremely important. And she's enjoying her physical activity. But she's still disappointed about not losing the weight that she wants to lose. And she's also still snacking in the evening, but realizes that she's not hungry. She's just eating. And so she is going to intensive behavioral therapy to talk about how to avoid doing that snacking. Intensive behavioral therapy is actually extremely important. And this is something that you can do, or if you don't have the ability or the time to do it the way that the patient needs, you can actually send this to another provider as well. As a matter of fact, using an interprofessional team can really help your patients meet the goals that they have overall. You also are monitoring her blood pressure and continuing to monitor her weight to see if she's meeting the desired effects of at least 5% of her body weight. And so Ellen comes back. It's now 16 weeks, and her blood pressure is still improved. Her heart rate's improved. Her vital signs look stable. But since being at maximum dose of the medication, she's only lost 3 pounds. She's still eating well, and she's still having physical activity that's consistent. And so now it's time to consider a different medication to see if this is going to be appropriate for Ellen. And again, when we're looking at ineffective response to therapy, we're looking at least a 5% weight loss in that 12-week period of time. If patients don't do that, then you want to consider whether another medication could be used, especially if that medication is at maximum dose. So with Ellen's case, with a less than 3% weight reduction, then we're definitely going to want to consider putting her on a different medication. And so, understanding the chronicity and the complexity of obesity, once we do get Ellen to her goal of starting her on an effective medication, as well as continuing with lifestyle modification, we then want to also consider how do we maintain that weight reduction. Weight recurrence typically occurs when medication is stopped. So if you have a patient on a medication that's working for them, I always say keep them on it as long as it works, as long as they can tolerate it, and as long as they can afford the medication because this is a chronic disease. We also know that successful obesity treatment includes self monitoring and tracking, frequent visits on a regular basis. These are not patients that you want to have come back after several months. You want to see them at least monthly, if not even more frequent than that. But remember, you don't have to always be the only one seeing them. You can utilize an interprofessional team to help those patients have those touch points. Maintaining weight reduction is made by difficult reduction by Maintaining weight reduction is made difficult when we have a reduction in energy expenditure that the weight reduction induces. So, definitely making sure that your patients is engaging in physical activity and strength training and also eating a balanced diet is important. And we want to make sure that we're treating our patients long term to be able to reach their goals. And so, what are the key takeaways from this discussion? First of all, it's understanding that obesity is a chronic and progressive disease state, but that it is treatable. Obesity management is not just about simply reducing numbers on the scale, but it is a comprehensive plan that we want to have for our patients to help them achieve their overall health goals. Intensify treatment with pharmacology and maximize the dose, but then evaluate for treatment success with medication at 12 weeks. And when necessary, you may have to try another medication. When they do have success, however, continue that medication management and see that patient regularly so that they can stay compliant and that they can ultimately achieve their overall goals. Thank you very much. Remember to complete the post test and the evaluation.
Questions? Anyone to redo anything? Are we all happy? Yeah, it was a little long, but I think we'll have to see where it comes at once we get to editing. Do I have my wrong headphones on? Yeah, sorry, I have the wrong headphones on. It was a little long, so once we'll get to editing, we'll see where we come out with the final
Okay.
piece. But it went. I thought it sounded great.
Yeah, it was very good. Okay. Yeah, yeah,
Great.
me neither. Okay. All right then. Thank you all for such a great job and have a great weekend. We'll see you
Thank
later.
Yeah,
you.
thanks everyone for
Okay.
hanging in there on
Bye-bye.
Friday afternoon. I know it's later for you
Yes.
there on the East Coast than it is for me.